Hassan Ali. I welcome you all to this session on surgical retina video session. So I would like to request Professor Dr. Khalid Maheen Saab to please take the seat as chair of this session, sir. Thank you very much. Our co-chair is Dr. Qasim Lateef Chaudhary. He will be joining us shortly. And we're going to straight away start. I'm going to invite our first speaker for today, Dr. Hamza Ali Tayyab, who will share with us two videos. First is on experience with ERM and ILMP, and the second is tackling giant retinal tear. Please welcome Dr. Hamza Ali Tayyab.
Bismillahirrahmanirrahim. Apologies for the sore throat. Working in LRBT Township as senior ophthalmologist. So I'm going to discuss two videos with you. And this is the first one. I think the retinal membrane, we will normally start with a choroidectomy. Then we inject intrabuccal triamcinolone. We use LMP dye. I think the resolution is not that nice. LMP is used for scanning the internal membrane, but it helps us delineate an edge of epiretinal membrane. So, first of all, whenever we are performing a surgery involving an epiretinal membrane, we try to create a space between the epiretinal membrane and the underlying retina. And we should be careful not to cause a pinch, small hypergenic lesions to the retina. So as you can see, I have stained the macula with the LMP dye, and then I was successful in peeling the epiretinal membrane. This, I think, case was a termination. This is the second case. This is also a case in which the usual steps of epiretinal peeling were performed. The choroidectomy is being done, and after the choroidectomy, we will inject intravitreal triamcinolone. The basic principle of injecting intravitreal triamcinolone is that if there is any posterior voltage detachment that needs to be done, sometimes there is an associated posterior voltage detachment with the epiretinal membrane. So we do that first. As usual, we will stain the macula under air. You can stain it without in saline also, but this helps ensure a better staining of the macula. While removing the epiretinal membrane, it's always better to remove the epiretinal membrane in a tangential manner. If you try to pull it upwards, you might cause an hypergenic retinal break. Just think that you are performing a continuous curvilinear capsulorhexis. You have to observe the underlying retina while performing an epiretinal membrane peel to make sure that the pull is not, the shear stress induced on the retina is not so much that it causes an hypergenic break. This is a persistent epiretinal membrane. I was successful in removing it from one side, but as you can see, the free edge is very near the fovea, so we have to be very careful. And also, after retrospectively observing two cases that I did, It's better to keep the light pipe away from the surface of the retina. It induces the phototoxic effect of the light. So after a few attempts, you can also now I'm finally able to clear it away. So try to keep the movement of your forceps in a tangential manner following the curve of the retina. If you go straight, you will end up hitting the retina. And here I've removed it. This is the last bit. And that concludes my presentation on epiretinal and ILMP. So my next presentation, there that involves, in very simple terms, more than 90 degrees involvement of the retina. The principles are generally the same. Here I'm trimming the anterior border. This is an important step. This is the anterior border of the tail. The importance of removing this anterior border is that if we leave this anterior border, we can cause a new vascularization response from these ischemic parts of the retina after a few months. So better to remove them. And as you can see, the whole retina is 180 degrees folded on itself. The best tool to use is PFCL, heavy liquid. If there's a lot of PVR, I've not really encountered giant retinal tear with a lot of PVR, but if there's a lot of PVR, sometimes it can cause very difficulty in unfolding of the retina. And here I'm applying intravitreal endolaser to the margins of the giant retinal tear break. So the retina, the posterior pole, the superior part of the retina have been stabilized by the heavy liquid. In this case, I mainly made 3 to 4 rows of laser along the break. But in my experience, after 3 to 4 years of doing retinal surgery, I mainly believe that if the tear is involved the large segment of the retina, try to do the barrage in a PRP style up to the arcades. I also augmented with cyclotropin. All the margins are handled also with laser and dry. So there are multiple. There is the most safe way which prevents the rolling back of the retina is an exchange of heavy liquid and silicone oil. The main problem in this is the most stable way of dealing with this giant retinal tear. The only problem is that you can sometimes, due to visualization problem, might leave a few droplets of heavy liquid PFCL on the posterior pole. So here I'm bringing the PFCL. The point where I stop injecting silicone oil is when I notice that the disc becomes a little bit pale, which is an indication for me that the intraocular pressure has risen beyond a certain point here. Now, I don't have a pointer, but I don't know how the audience can see, but you can appreciate the edge of the PFCL liquid bubble. Visualization is everything in retina. The better you can visualize it, the more comprehensively you can perform the surgery. So now, after checking the intraocular pressure in the end, we conclude the case. Thank you so much. Any questions? ऐसे
Any questions? Comment? Acha, very nice presentation.
all they had was an epilepsy membrane. There was no other surgery done.
In my experience, I find that doing simple vitrectomy for ERM removal is not very rewarding visually. Patients don't usually say that we have noticed a dramatic improvement in our vision. So the best indication for removal of epiretinal membranes are eyes which are symptomatic with cotton wool spots visibly seen on the retina. So अगर तो आप acute epiretinal membranes जो होती है जिनके अंदर cotton wool spots आपको नजर आते हैं, actually मैंने इसको 20 साल पहले publish भी किया था, and we compared to both categories of patients जिनको जो symptoms के साथ आए retinal clinic पे और आपने देखा कि ERM है और साथ cotton wool spots हैं, फौरन ऑपरेट करें, उन्हें बहुत अच्छे रिजल्ट्स क्योंकि उनको acute ischemia exoplasmic flow में हुआ होता है, आप membrane remove करते हैं, ischemia cotton wool spots take about 8 to 10 days after removal to disappear, and the vision usually इनकी vision भी कम नहीं होती, like 6/24, 6/18 और 6/9 तक हो जाती है। बाकी हम अपने क्लिनिक्स पे रेटिनल क्लिनिक में बहुत कॉमनली ERMs तो बहुत होती है, कैटरेक्ट कराने हैं पेशेंट की, उसको ERM भी है और कैटरेक्ट भी है, क्या करें। ERM के साथ बहुत अच्छी पेशेंट के साथ लोग गुजार रहे होते हैं, उनका टाइम गुजर रहा होता है और हम उनको रिमूव करते हैं, वो कहते हैं आप इतना बड़ा ऑपरेशन किया है सर, मुझे बिल्कुल नहीं लग रहा। सो ये आपने सिम्प्टोमेटिक ERMs अदरवाइज काफी बड़ा रिस्क जो चांस लेते हैं आप विट्रेक्टमी करके ERM रिमूव कर रहे हैं, अगर तो पेशेंट को डेफिनेट फायदा होना है तो आप जरूर करें, लेकिन ये टेक होम मैसेज आज का ये है कि आप खुद नोट करना कि सिंपल ERM आप रिमूव करते हैं अनलेस कि उसने मैकुला को यहाँ तक उठाया हुआ है, वो भी नहीं, उसमें भी अंदर स्ट्रक्चरल चेंजेस इतनी आगे होती हैं कि अपने आप को फैसिलिटी देने के लिए रिमूव कर रहे होते हैं, लेकिन आप दिल में देखना कि पेशेंट जो है उसको वो इतना बेनिफिट नहीं बताता कि मुझे बहुत फर्क पड़ा।
सर अगर देखिए हमने अपनी हॉस्पिटल में देखे ERM अगर कुछ देर हम पड़ी रहेंगे तो ओवर टाइम वो मैकुलर एट्रोफी सिस्टिक स्पेसेस आती हैं, फिर उसको रिमूव करें तो वो लैमेलर होल मैकुलर होल में ज्यादा चांस बन जाता है। अब अगर उसको अर्ली रिमूव किया जाए 6/12 पार्शियल पे या तो उसमें मैंने देखा कि थोड़ी विजुअल इंप्रूवमेंट बेहतर आती है।
नहीं, I don't agree with you at all on this one.
If there is no diabetes history,
कुछ भी डायबिटिक्स में भी है फील करेंगे तो आप पहली फ्राइबल फ्रेजाइल रेटिना है
जी सर,
उसका मैकुला वैसे ही कॉम्प्रोमाइज्ड है, उसके आप खींचे
अब there are cystic spaces, if there are cystic spaces, edema leakage,
हाँ,
and there
तो
periods of membrane,
जो अगर
then
रीजन है उसका कॉज को कुछ और
हाँ कुछ और है।
एंटीवेंजन लगे। मैं आपको मतलब ये कहने की कोशिश कर रहा हूँ कि मुझे भी बहुत अच्छा हो गया इस गेम में। सो सिम्प्टोमेटिक ERMs वो हैं जो विजुअल लॉस के साथ प्रेजेंट करती हैं। जो आपके पास एक पेशेंट आ जाए, जो आपके पास एक पेशेंट आए जिसको आप एक्सीडेंटली देखो यार इसको ERM है, विजन इसकी थोड़ी सी ड्रॉप है, उसको रिमूव करने पे आपको विजन में इंप्रूवमेंट बहुत रेयरली मिलती है। सो इफ यू सी cotton wool spots with ERM, yes, you have to remove it.
लेकिन सर इसके बारे में आपका क्या एक्सपीरियंस है? बुक ने लिखा है constant traction यानी elevation of the retina, it will lead to degeneration of the photoreceptor layer। ये मेरे ख्याल में जो न्यूकास्ट के अमेरिकन के
देखिए आपने विजन को भी तो देखना है, बहुत
ना वो तो मेटामॉर्फोसिस से जब तक ना होगा पेशेंट खुश नहीं होगा, ये तो कंफर्म बात है।
हाँ, जब तक मेटामॉर्फोसिया उसको अगर बहुत मेटामॉर्फोसिया है तो जरूर करना है,
हाँ वो खुश होगा,
और अगर वो एसिम्प्टोमेटिक अदरवाइज है थोड़ा सा विजुअल लॉस है उसको और आप मेम्ब्रेन देख रहे हो तो
I will not
remove it.
they will not
Sir, I want to ask one question. Despite removal of the ERM, sometimes
Yes.
patients do not respond. Their macular edema doesn't get better. So
Yes.
then what should we do?
Well, then you obviously the only option that you have is to give them anti-VEGF. That's the only option. You can do combination therapy. You steroid के साथ आप देख सकते हो। कई बहुत resilient हैं, बहुत resilient। उसमें आर्गुमेंट ये हो सकती है कि आप उनकी आगे में क्यों कासिम है ना, अगर आपने एक सर्जिकल ईयर रिमूव की है और मैकुला जो है अभी भी उतना ही थिक है, तो एंटी VEGF is not a bad option to start off with. And if it doesn't respond, some of them will never sort of need if you want to understand.
And what is your experience on using anti-VEGF in these patients? I mean, sometimes कहते हैं कि वो उसको और ज़्यादा contract करेगा।
मैंने ये देखा है कि जो इस तरह के पेशेंट हैं उनके विजुअल आउटकम बहुत ज़्यादा बेहतर नहीं होता, they don't visually improve, anti-VEGF लगा के भी maybe structurally या OCT में you will notice less thickening, but जो इस तरह का resilient macular edema होता है उसका visual prognosis with I would say with guarded. So whatever you do, you have to tell the patient. असल चीज ये है कि have you counseled the patient, because ये वो चीजें हैं जिसपे काउंसलिंग का बहुत ज्यादा रोल है. So आप उन्हें ऑप्शंस दे रहे हैं कि don't show them the greenest side of the picture. Tell them that nothing to lose by giving you anti-VEGF, but they may not help you with much more improvement in vision. Thank you, sir. अच्छा वो सॉरी आपने जी जॉइंट रेटिनल दिखा रहे थे आप, उसमें आपने हेवी लिक्विड और ऑयल एक्सचेंज किया है. अच्छा मैंने एक पॉइंट इस पे बताना था, ये भी तजुर्बा होता है नहीं, तो आपके पास एक जीआरटी के साथ पेशेंट डिजाइन करता है, उसमें आगे से ज्यादा रेटिना डिटैच है, थोड़ी सी देर तो बची भी हुई है ना, तो मैंने अब ये नया काम शुरू किया है कुछ सालों है उसको फ्री ऑफ लेजर से उसको लेजर करते हैं, बराज करते हैं. तो क्या उसमें मैंने देखा फायदा कि ड्यूरिंग सर्जरी वो अनसेफ नहीं होता है, वरना जॉइंट रेटिनल टियर जो है जब आप शुरू करते हो सर्जरी, सो एक टियर बना हुआ है, जाहिर है वहाँ पे कोई वीक एरिया है, डिजनरेशन है, क्योंकि वहाँ से होती जाती है कई दफा, तो वो बड़ा होता जा रहा है. तो अगर आप उस पूरे एरिया को सिक्योर कर लें, और मैं तो ये देखा जितनी भी रेटिना को अटैच आप रेटिना को लेजर करके सील कर दो, तो आपकी सर्जरी बहुत आसान हो जाती है. So retinal detachment is limited to that sort of area. उसकी दूसरे की फिक्र नहीं आपको बनेगी.
सर जो रेटिनल स्लिपेज वाला मैटर होता है जीआरटी में, उसके आपके क्या प्रोडक्ट्स हैं कि आप उसको PFC से सील कर रहे हैं?
हाँ, उसमें स्लिपेज होने का कोई चांस नहीं है. अगर आप डायरेक्ट कोई PFC या ऑयल एक्सचेंज कर रहे हैं कोई स्लिपेज का चांस नहीं है. लेकिन अगर आप पहले और एयर फ्लूइड एक्सचेंज करते हैं, उसके बाद ऑयल डालते हैं तो स्लिपेज होती है. सो simple message is यही है कि you have to do heavy liquid oil exchange, and obviously most machines have this facility, you can simultaneously do it. In Constellation you have this क्या कहते हैं facility कि आप साथ साथ oil inject करते जाओ, साथ साथ आप aspirate करते जाओ heavy liquid. So उसके अलावा there is no other option, आपके पास है नहीं कोई option. Slippage होती है तो फिर you have to go back, तो दोबारा आप ऑयल डाल दिया तो उसको निकालोगे, उसके बाद दोबारा उसको फ्लैट करोगे हेवी लिक्विड के साथ, फिर ऑयल सील करोगे.
सर इसके बारे में एक और ऑप्शन ये भी हो सकता है कि आप हेवी लिक्विड छोड़ दें फॉर 2 वीक्स, और लेजर तो इट विल स्टार्ट वर्क इन आवर्स एंड इट विल इफेक्टिव आफ्टर 1 वीक. तो 2 वीक्स के बाद ये रिमूव कर लें गेज या ऑयल से इसको रिप्लेस करें.
मैं आपको भी केस दिखाऊंगा जिसमें मैंने छोड़ा था हेवी लिक्विड बहुत सीवियर रिएक्शन कॉज करता है. ठीक है, कुछ आईज में ओवर बहुत ही ज्यादा करता है, हेवी लिक्विड की हम बात करते हैं.
ये भी सर.
सो फिर वो दूसरा उसकी टॉक्सिसिटी. सो आई एम नॉट अ बिग फैन ऑफ लीविंग हेवी लिक्विड इन द आई.
हमने एक मेथड तो 2 हफ्ते बाद हमने रिमूव कर दिया तो ठीक होगा, रिएक्शन जाहिर बात है.
और उसके बाद फिर आप रेटिना की फीलिंग सरफेस के ऊपर इन्फ्लेमेटरी मेम्ब्रेन्स बन जाती है और आप एक मुसीबत से निकल के दूसरी मुसीबत में जाते हैं.
So thank you very much, Dr. Hamza, for giving us a very good presentation and generating a lot of questions for this form, and very well done. Excellent. So our next speaker is Dr. Bilal Khan from KPK. He also has 2 videos to show us today. He will be talking about removal of dropped IOL, vesicular fixation, and macular hole surgery in detached retina. Dr. Bilal Khan from KPK.
Is Dr. Bilal Khan, working as assistant professor in Khyber Teaching Hospital, Peshawar.
So this is a case of drop IL. Now I am doing PVD, posterior ventral detachment. Now I'm putting this transformation flag. That's why it's important to. Now this is the transformation flag. IOL is not visible. Very. It is just at the 6 o'clock. So one should not pull the IL. One should do indentation. Will relieve this IL. Will relieve adhesions. Now this is the removal of the transformation flag. Now there is the indentation on this side. Now the IL is visible. Now you have the one haptic is just stuck there, and I'm relieving it. And you are seeing, I'm not pulling it, just to avoid any tear, any indentation. This is with indentation. One should be very patient during this time. Now the IL has been relieved there because just the posterior pole. I have already made a posterior flap at 1 o'clock because there is rim of the posterior capsule at from 7 to 5 to 8, 9 o'clock. So at one side, now just I am removing this IL with the forceps. It can also be removed with heavy liquid, but I am removing with forceps. Now inferiorly, the rim of the posterior capsule is visible. Neck has been found here at 1 o'clock. This is the proline, 10-0 proline. Superiorly from 12 o'clock to 4 o'clock, there is nothing there of the any remnant of the posterior capsule. One haptic is on the part of the posterior capsule, and the other haptic is stitched with the sclera. It is beautifully placed, and the patient is enjoying vision, good vision, with very less refractive error, almost 0.75, minus 0.75. I'm doing laser at that part from which it has been separated. So now there is another video which there is depicts retina with macular hole. Sorry. So this is the detached retina. This is the OCT in which there is a separation of the retina with the macular hole. I am doing a PVD, posterior vitreous detachment, which is difficult in young age and in children in early cases. But in pseudophakic patients, it is very easy. So here I am just doing PVD in detached retina. PVD has been done. Peripheral vitrectomy. Here peripheral vitrectomy is going on. That is macular hole in detached retina. This is retina here. Here fluid exchange was just to put brilliant blue in the air filled cavity. So after this I am putting this brilliant blue. But the main problem here is that the brilliant blue is going behind the retina. Now the whole retina is becoming blue. Now PFCL has been put after this. Now it is done. I am doing it in the PFCL filled cavity. I will put PFCL heavy liquid. In heavy liquid, it is very much difficult to elevate internal limiting membrane. But it will be easy for beginners to catch retina, then leave it. And at that case, it will be easy for elevation of this internal limiting membrane. So here it is not visible yet properly, but it will be visible. Now I then feeling is in progress. जिस तरह सर ने कहा टेंजेंशियल मिरर में आप करेंगे जिस तरह रेक्सिस बंद करता है इसी तरह आप करेंगे तो रेक्सिस इज ऑलमोस्ट गोइंग टू बी कंप्लीटेड and the flare collar has been put on the hole, macular hole. One flare has been put on the macular hole, so it has been done. The heavy liquid has been removed, laser has been done. I am removing the heavy liquid, and after that I am putting silicone eye. So after 2 to 3 weeks, almost after 1 month, when we are doing UCT, the macular hole has been closed. Retina is closed.
Any questions or comments for Dr. Bilal Khan?
I think one important message for doctors and professionals is that in a detached retinal situation where you have macular hole and macular detachment, it's a good idea to just put heavy liquid on top of the macular hole before you put the stent. Because a normal macular hole, which is an idiopathic macular hole, with no retinal detachment, can take that much pain in the back of the hole अगर आप नहीं भी उसे कोई किया, but अगर आपकी एक retina attached है और आपका उसमें मैक्रोमोनिजो जैसे ये दिखाया, तो उसकी टॉक्सिसिटी बड़ी वाइड स्प्रेड होने का रिस्क बढ़ जाता है। सो आपने उसको फ्लैट कर दें, उसके बाद उसके ऊपर आपने एक ड्रॉप ऑफ हैवी लिक्विड डाल दें, उसके बाद आप स्टेन करें। दूसरी बात जो सर ने बताई है वो ये है कि peeling in a detached retina is far more difficult than in otherwise macular wholesale. So counter traction का element आ जाता है ना उसमें, तो heavy liquid के साथ you have to be it's more laborious। ये बिल्कुल इसी तरह है जैसा आप एक बहुत ज्यादा विस्को इलास्टिक डाल के कैप्सुलर एक्सेस की कोशिश करते हैं, so आपको फ्लैप को उठाने नहीं देते आराम से। So अगर आपका less viscous होगा तो बड़े आराम से आप एक्सेस करते हैं। So heavy liquid आपको एडवांटेज भी दे रहा है कि उसने रेटिना को फ्लैट रखा हुआ है, but at the same time ये आपकी जो पुश एंड पुल है वो आई लाइन के लिए उसको रोकता है।
Thank you, sir. Our next speaker is Dr. Mohammad Awais Asghar from New Hospital. We'll be talking about segmenting and delamination, advanced surgical maneuvers for managing complex diabetic pericarditis.
Assalamualaikum. I am going to present segmentation and delamination, advanced surgical maneuvers for managing complex pericarditis. So all know the pathophysiology of infection, which causes FPPs and FPVs causes pericarditis. In any management of any TID case, first you all have to leave AP traction. For AP traction, you do a core retraction and truncate the vitreous, leading to release of traction into the posterior traction. And the second step is leaving the tangential traction by segmenting them, but they are only somehow cannot. So the first technique is outside leaning approach or moving approach. Where we start at very weak, we will truncate the vitreous where the vitreous has already detached from the retina, and then we start doing sensitivity towards the optic. There is a case that I did. We are first trying to find a space between the retina and posterior highlight. Really, I do this moving approach only in those cases where the retina has already detached from the vitreous in the pectoral part of the retina. Here, the vitreous has been located, and we are moving all around so that it is free from the FPPs. It has been flattening down the. Next, we are going to do segmentation of the individual membrane FPPs. We are going to find some space between the FPP and the retina, and then we are going to cut it to the retina. Next, I am going to use the forceps to and do some end of delamination. It is a very risky procedure. You get overexcited and do cause breaks. So that is the thing that you have to be watchful of. Really, you are putting it somewhere and you get a retinal break somewhere else. Really at the weakest point. So I did get a break here, put heavy liquid in to stabilize the retina, remove the remaining FPPs, and did a pericarditis with the PRP. The next technique is inside out technique, move out technique. I really do this technique only when the posterior vitreous is quite tight and there is no space between the peripheral part of the retina, vitreous and retina. We usually start at the disc, we're pulling at the disc. Usually the retina is quite up at the disc and it allows separation to happen between the posterior vitreous and retina. If you try it anywhere else, it will lead to a retinal hole. So here's another where we have started at the disc and we have started segmenting after pulling the retina. at the wrist and you do segmentation with the cutter and delamination with the cutter. If you do a delamination with a hand gripping forceps or max grip forceps, you really need to breaks, multiple breaks, and you really end up having more problems rather than the rest. Delaminating and segmenting with the cutter at quite from 5,000, 6,000 cut rate and a vacuum of 50 to 100 milliliter of mercury gives good segmentation and delamination. Good post operative. No. And really, I end up using max grip forceps and gripping forceps just to localize the spaces where I have to get it into use the cutter for it. If you use a higher cut rate, then FVPs don't get into the mouth of the cutter and you just end up spending more time on it. If you use low cut rate, the retina gets into the cutter's mouth and you have a break there. So the segmentation still it's a divided market, I think, where you segment the visual FVPs and then delaminate them. Multiple instruments are available for segmenting. You can use a vertical scissor or a horizontal scissor. Vertical scissor have a problem. You can use it as a pick, and I have seen very tight spaces where you want to get into between the FVP and the retina. You really create a break there with the pick of the vertical scissor. So I have resorted to only using the cutter to do the segmentation. Secondly, horizontal peeling. The smallest the gauge, the highest the gauge, smaller gauge cutters really can easily pass between the FVPs and the retina. The larger the cutter bore, it will be difficult for the cutter to get those spaces. And as I had demonstrated earlier, to use the hand gripping forceps to create and block the section really creates more problem. This is the comparison of the ruler that I already described. This is 27 already described as the surgical arsenal. So the bimanual dissection technique is a newer technique with chandelier illumination. We have tried a few cases, but you are really not very good at that. And I have more expertise in using the single cutter as a retractor and doing delamination and segmentation. Sir has more expertise regarding that. So you must provide heterogenic vector techniques and you must control the intraoperative reading with fictitious endocautery and other problems with length touch and other anterior vitreous problems must be managed and controlled to use it. And you really end up with 92% economical detachment rate, 75% improvement rate, and only 15 to 20% cases do have recurrent retinal detachment in which you have breaks and you have not cleared the FVPs completely.
Very good presentation. Diabetics reflectors are my favorite techniques. I love them. उसमें जो मैं आपको मैं एक्सपीरियंस से बताऊं, एक तो ये कि बायोमैनुअल से के अलावा कोई चांस ही नहीं है आपको डायबिटिक टेक्निक यू हैव टू डू बायोमैनुअल, ठीक है, चैंडिलियर लगा के पूर मेंस चैंडिलियर भी बनते हैं
तो सर आप वो प्रॉब्लम की होती है कि वो एक ही जगह फोकस कर रहे होते हैं, बहुत ज्यादा वो पैनोरामिक
ऊपर नीचे दोनों जगह लगा दो, स्पीड पे दोनों लगा दो,
या ये हो सकता है कि वो जो असिस्टेंट होता है वो फिर उसको मैनिपुलेट करके आपको व्यू दे देता है.
अच्छा, उसकी वजह मैं आपको बताऊंगी. डायबिटिक्स टेक्निक्स आर डिफरेंट फ्रॉम अदर्स. व्हाई? बिकॉज you don't want to keep put oil in these eyes, ठीक है, क्योंकि वो नहीं डालना और वो क्योंकि आपने ऑयल नहीं डालना इसलिए you cannot afford to have a break, you cannot create a break. और जिस तरह आप मैनिपुलेट कर रहे हो बेटे सिंगल हैंड के साथ, you don't have as much control as you have when you are using a forceps and scissors and dissecting in the right planes. और आपके कासिम को ये भी बहुत अच्छे बन गए होंगे, हमारी फिंगर टिप्स में सेंसर्स हैं, अब बन जाते हैं कि आपने कितना पुल करना है, अभी थोड़ा सा और करो तो ब्रेक बन जाएगी। यू ऑलरेडी नो कि आपकी लिमिटेशन क्या है। सो द ब्यूटी ऑफ डायबिटिक विट्रेक्टमी इज नॉट टू प्रोड्यूस एन iatrogenic ब्रेक, ठीक है। इसमें मेरी यूरोपियन सर्जन से बहुत आर्गुमेंट्स हो चुकी हैं, वो कहते हैं बनती है, मैं कहता हूँ नहीं बनती यार, नहीं, मतलब अगर आप केयरफुल करें तो आप यू कैन अवॉइड creating iatrogenic break. The only reason for putting oil in these patients is because you have a break. ठीक है? Otherwise इसकी कितने complications हैं? Blood vision, oil toxicity, secondary glaucoma, cataract, पहले ही compromise रहता है। So आपने diabetic विट्रेक्टमी आज के बाद जब करने का सोचना है, आपने कहना है यार ये हमने ये नई चीजें हमें इंजेक्ट की हैं, मतलब मेरी तरफ से कि आपने ये सोचना कि यार इसमें ऑयल नहीं डालना, जो मर्जी हो जाए ऑयल नहीं डालना, और रीब्लीड क्यों हो उसमें, आप इतनी अच्छी उसकी लेजर करें, और अगर पेशेंट थोड़ा अफोर्ड कर सके तो उसको प्री ऑफ या पोस्ट ऑफ एंटीबायोटिक बताएं। ब्रिलियंट रिजल्ट्स हैं इनके अगर आप इनको प्रॉपर्ली करें, और डिजास्टर है अगर आप इनमें ब्रेक्स प्रोड्यूस करें। सो दोनों एंड्स हैं आपके पास, बट आपने बहुत अच्छा प्रेजेंट किया। आप कोशिश करो कि बायोमैनुअल जब इतनी एडवांसमेंट्स हैं आगे में, क्या बायोमैनुअल कर सकते हो। डायबिटिक्स में तो आपको 4-5 कोर्स भी बनाने पड़ते हैं, कई दफा आपको टेम्पोरल साइड पे बैठ के सुपीरियर फीलिंग करनी पड़ती है, कई दफा आपको नेजल साइड पे बैठ के इंफ्रोटेम्पोरल या सुप्रोटेम्पोरल, और you can move around ना। The trocars have given you this great advantage कि आप मूव अराउंड कर सकते हो, एक एक्स्ट्रा ट्रोकार लगाओ, कोई आपको पुराने जमाने के विट्रेक्टमी वाले चक्कर नहीं है कि यार अब एक और कैनुला लगाऊं और मैं यहाँ से कोड बनाऊं, सीधा ट्रोकार लगाएं। मैं तो 360 में भी घूमता हूँ, और बहुत ज्यादा अच्छे रिजल्ट्स हैं। You have to get rid of the membranes of the surface of the retina without producing a break.
Because sir, we are afraid of this witness. हम एक दो पेशेंट देखे फिर हम डरते हैं, हमसे दिखाने हटाते हैं।
सर नहीं डालना, आप ना डाल के देखें, आपको विट्रियस हेमरेज उसी सूरत में होगा कि आपने उसमें उसमें आपने लेजर कम की है या आपने आप एंटीबायोटिक लगाएं, उस पेशेंट को मिले या आप
बाद में लगा, एट द एंड आपको
प्री ये लगा लेना, सर्जरी से 4-5 दिन पहले लगाएं, वो तो लगा सकता
मेरा ख्याल है कि
जब ये जो मेम्ब्रेन को एलिवेट कर देते हैं, काट देते हैं, तो वहाँ कुछ ना कुछ ब्लीडिंग हो जाता है।
आपने जब भी काटना है को काटें, और जो डिस्क से फ्रॉन्ट आ रहा होता है उसको तो आप डायटर नहीं करके डिस्क तक ले लेना, इतना से रह जाएगा, वो ब्लीडिंग कैसी होती है,
ब्लीडिंग जैसे होते हैं। हम कभी-कभी वहाँ छोड़ देते हैं, रिकॉर्ड करने
क्यों छोड़ देते हैं,
तो यही ब्लीडिंग
कॉलीफ्लावर को बिल्कुल खत्म कर दें। हां, उधर से ही तो आती है,
कैंसर नहीं है, जो मूवमेंट आपका कैंसर वो बैक
पूरा ही उड़ेगा,
बिकॉज़ दैट इज वो ब्लीड वो डेटा।
अच्छा आप ये बायोमैनुअल करोगे ना स्टार्ट, आप नोट करोगे कि अल्लाह ताला ने बहुत ही रिलैक्सेशन दी हुई है डायबिटिक विट्रेक्टमी में। मतलब आप मेम्ब्रेन को पुल करोगे, पैक्स ऐसे होते हैं, ठीक है, आपने पैक्स को काटते जाना है, और आप मिरेकलसली आप कहते हो ये सारी मेम्ब्रेन रुक गई है विदाउट एनी ब्रेक।
और एक मिथ भी कर रही है कि अगर आपकी ओडी आई है या बायलेटरल विट्रियस हेमरेज तो एटलीस्ट एक में ऑयल डाल दें ताकि पेशेंट जो है वो,
ये कौन सी मिथ है यार, हमने जो
सीरियस हमेशा बात है।
सर एक और बात है, ये तो रेटिना एलिवेटेड होता है ना डिफ्रेक्शन, अगर आप ऑयल नहीं करेंगे तो ये आप एक्सपीरियंस की बात कर रहा हूं, तो ये बाद में बैठ जाती है।
मैं आपको बताऊं ये 20 साल पहले मेरा भी यही ख्याल था कि इसको ऑयल डालेंगे तो बैठ जाएगी।
हां ये
सर आपने अगर उसकी कॉज रिमूव कर दी है तो फिर वो बैठेगी ही बैठेगी और बैठती है, अट्रैक्शन के साथ बहुत ज्यादा रेटिना एडिमा हुआ होता है, तो आप जब रिमूव करते हैं गिव इट 1 मंथ इट विल सेटल ऑन इट्स ओन। बिलाल साहब आपका क्या कमेंट है?
सर मैं तो ये है कि डायबिटिक विट्रेक्टमी है, फर्स्ट स्टेप आई डू इज सेपरेट पेरिफेरल एरियाज फ्रॉम द पोस्टीरियर, क्योंकि मेन चीज ये है कि यू आर वर्किंग द पोस्टीरियर पोर्शन क्रिएट लाइक उसमें सबसे पहले नॉट अ ह्यूज अमाउंट ऑफ कैनुला और स्मॉल डस्टिंग करके यू लुक एट इट कट ऑल अराउंड, देन दैट Arif is saying exclusively most of the cases are binary, उसमें you put it on the nasal side, फिर एक पेशेंट में थोड़ा सा आपको ध्यान रखना होता है कि touch, lens की touch या फिर proximity है. Bimanual gives you a very good dissection of the periphery. You do the dissection of the membranes, remember the remaining vitreous at the periphery, and much more complete laser. क्योंकि यहाँ पे जो laser probes होती हैं, eliminated भी बड़ी जल्दी खराब होती हैं. एक दो uses के बाद जो है वो खत्म हो जाती है. You can do much better laser. और उसके बाद don't chase every area of fibrosis. Don't give your surgery by removing the nasal fibrosis. You can leave some of the nasal fibrosis there.
उधर से ही ब्रेक बनती है
क्योंकि आप greedy हो जाते हैं कि यार मैं I want to remove every shred of fibrosis.
सर्जन की हिट जो है ना वो तो सारे
जी वो उसमें तो basically you can clear the macula and then you can use gas. I mean we use oil. There's no monocular patient जो कि या positioning के issues हैं या बाकी चीजें हैं.
Towards our last speaker, we're very fortunate to have Professor Dr. Khalid Meesa with us today, and he is going to show us extremely challenging cases today. So first of all is detachment in uveal interference syndrome, and followed by a case which has keratoprosthesis and only eye has within detachment. Professor Khalid Meesa.
Visual blurring, which was bilateral. I would call it subacute, and her vision had dropped from 6.6 to 6.18 in one eye and round finger in the other. And on examination, she had bilateral bullous exudative retinal detachment. One was so massive that it had obviously encroached onto the macula. The other one was just at the edge of the macula. So the first thing in my mind was, what is the diagnosis? She did not have any indication. After when she presented, to my horror, I noticed that she had 5 massive islands of subretinal fibrosis, and it was like 5 trampolines sitting on her retina, and each ring of that trampoline was elevated just like a tabletop, and so and her vision had dropped to hand movement. So I thought that it's a good indication to do a vitrectomy in her case. So let's move on with that. So the idea of showing you this patient is to know how to deal with patients with subretinal fibrosis, how to remove subretinal bands. Now, normally we encounter 1, maximum 2 bands, and sometimes we like to leave them if they are inert and not encroaching on the macula, and sometimes we have to remove them. But having 5 trampoline rings on the retina really warranted surgical intervention. So here she is. This is the macular area, and this ring is encroaching, passing through the macula onto the disc. I'm at the moment examining the extent of the problems. This was subretinal exudates. Apologize for the quality of the video. So not only am I checking how many are there, but also how badly they are elevating the retina. This one is going inferiorly. So the usual way of dealing with them, with these bands, are in order to remove them, you have to do multiple retinotomies. Since there were 5 of them, so you have to first of all imagine you have to do 5 retinotomies, and you ensure that the blood vessels are properly cauterized around the retinotomy, so that when you go inside the hole and try to pick up the band, you do not induce any bleeding, because that will go immediately subretinal, and you will not be able to do anything about it. At the same time, so I've created 3 retinotomies already. Now there are various ways of removing the bands. One is the spaghetti technique where you do bimanual removal. You make two retinotomies at either ends of the band, and using two forceps, you try to disengage the bands from the undersurface of the retina. Now this is all pre-retinal hemorrhage which I'll be able to remove. So cutter in this situation is cutting and aspirating alternately. There was huge amount of yellow subretinal fluid. Obviously, we all know that when you develop exudative detachments, you always get yellow fluid. But then the other important thing is not to lose your calm. I'm not a very big fan of using perfluorocarbons in retinal surgery unless you have giant retinal tears. So I find that if you can manage without the use of perfluorocarbon, it is probably a good idea. Now the macula is beginning to sit, and the elevation looks a lot better. This band here is very, very thick. Now, whenever you are dealing with the subretinal band, which is in close proximity to the macula, it's very important to keep in mind the physics of pull, because if you pull slightly, in the wrong direction, you can easily produce a macular hole. Sorry. Sorry about that. Yeah. So the only plus with this technique is that you have 5 areas, 5 sites to drain. So you can you rest assured that you will have a flat retina. So every point where there was an elevation, you've already got your retinotomy, you've already removed the subretinal band from that point, and then you can drain the residual fluid from that point. So you drain the fluid, but you don't necessarily have to go to all those 5 points. I just mean that if there is any residual fluid left in any area, it's very easy to flute it out. And then obviously you laser all these areas, and in this case, obviously you have no option but to put silicone oil. So the patient did very well and is still doing very well. She still has oil in the eye. She has 660 vision with oil in, and I'm waiting for probably another couple of months before I remove her oil.
It was diabetic or poor stitches. Yeah, it was chronic.
I think it was idiopathic uveal effusion syndrome.
There was telangiectatic.
Uveal effusion syndrome does not have it's an idiopathic condition in which you do not have you have exudative detachment without inflammation in the eye. But the next couple of cases that I'm showing you again are vitreoretinal challenges. I call them from north to south, so from the front to the back of the eye. The first patient that I have here is a 28-year-old male who had chemical burns. Some acid was thrown on his face. So he had, corneal. He had a very dry eye, and obviously corneal scar. So I actually referred him to India for keratoprosthesis, where they did a modified Boston keratoprosthesis because his retina was absolutely fine. So he had the keratoprosthesis done, and then he came back, and I saw him after that, and he had very decent vision. couple of months after that, he detached his retina and was seen by somewhere else, and he underwent a vitrectomy and oil. But a week later, he presented to me with certain loss of vision, and when I saw him, he had total retinal detachment and subretinal oil and a giant retinal tear. So it was very, very sort of alarming in somebody who develops this in an only eye, and he literally had perception of night vision. So the idea of showing the video is that first of all, as we are surgeons, we think, how are we going to fix this retina? Which viewing system is going to help us look through the keratoprosthesis, because it is, Boston keratoprosthesis is slightly different from the temporary keratoprosthesis that we use otherwise in patients with scarred cornea. Can you go to the video, please? So इधर से आप देख सकते हैं कि रेटिना बिल्कुल साथ प्रोसेस का डिटैच्ड रेटिना आपको नजर आ रही है. So ऑयल पहला क्वेश्चन तो ये है कि हमने इसके पोर्ट्स कहाँ बनाए हैं. So I went in and obviously I was expecting this to be almost a closed retinal detachment, and I tried to do bimanual peelings from on the surface of the retina. Remove the oil first, obviously, and tried every trick in the trade to try to flatten the retina, but there was so much of subretinal fibrosis and retinal thickening and redundancy, that lack of redundancy, that I thought that the only way forward was to do a 360-degree retinectomy. But again, the viewing system, you only could see the central part of the retina. As you wanted to go to the periphery, the view was suboptimal, and you weren't sure what you were doing. So the message here, that from my experience, is that in these particular cases, you only want to do what you see. You can only do what you see. So don't try to peep into the periphery much, and in that case, a 360-degree retinectomy and flattening the retina with heavy liquid first, and then oiling and lasering these patient is probably the best bet. He is just about count fingers, and that's the maximum he can get out of this. Shortly of time. उसमें आपको बहुत ज्यादा इसलिए भी नजर नहीं आ रहा कि सर्जन को भी ज्यादा नजर नहीं आ रहा. केराटोप्रोस्थेसिस भी मिलेगा. अगला केस भी 21-year-old है लड़का. He had a failed corneal graft, a dropped IOL, and a total retinal detachment for about 6 months. Since he had good projection, and this was his only eye, he had already lost the other eye. Since he had good projection, I thought that it's worth giving him a go. So the plan was to first of all do his penetrating rhinoplasty, followed by removal of the dropped PMMA, and the haptics of those that lens were also broken. So it was again challenging how to pick it up from the back of the eye and then deal with his retinal detachment. So his graft, initially his eye was so hypotenuse. To do a graft in these patients is a nightmare, because a soft or hypotenuse eye will not let you do a perfect graft. So the graft was done initially, and then we waited for 2 weeks for the wound to sort of mature a little bit. The eye is so soft that it would not let the trocar enter the eye easily. So now we are preparing to actually remove the dropped intraocular lens. Mirror, please. So here you see the dropped IOL, and it's just the optic. And the scary part is because it's PMMA, you have to have a large wound to remove it. So for those who are still in training, always make sure that you have a bigger wound when you're removing the lens. Do not do not make a smaller wound. Otherwise, you'll be struggling while you're removing the lens. It is quite hard job to pick it up and bring it right where it should be. And if you have a smaller cut, smaller wound, and you also have to make sure it's not just the scleral wound, it's the uveal cut inside as well. That has to be exactly the same, if not bigger size. So once we remove the lens, then we have to deal with this very sort of ischemic retina, which is detached with multiple epiretinal membranes, severe PVR. So again, we have to do bimanual peeling. In these cases, you can't do anything less. And finally, we have managed to attach the retina and oil the eye. So the take-home message is that in patients, these are very precious and very highly demanding eyes. That if you have somebody with a failed corneal graft and with the dropped IOL and the total retinal detachment, you should still take a chance. And leaving them with even ambulatory vision is better than NPL. Thank you.
Thank you very much all for your attending this session. I would like to request our worthy chairman, co-chair to please come forward and all the audience for a picture. Thank you very much for attending. Really appreciate it.